Hi, good evening. I'm Dr. Brett Puckett, working with Southeast Orthopedic Specialists, and I'm a hand, wrist, and elbow specialist, and really excited about this opportunity to have this seminar and kind of explain the basics of carpal tunnel syndrome, to go through the what it is, how to tell it from other things, and how to take care of it. And hopefully answering some good questions at the end of this. Really looking forward to that, and it's a big part of what these seminars are for, to be able to have some of that feedback and some of those questions, because very often they get to something really important about the topic that we're talking about. So I'm going to go through the basics. The point of this, again, is an overall understanding. There are certainly specifics, and feel free to type in questions and ask those that I'm going to try to get to at the end of the seminar. There's plenty of time to talk and answer questions later on, but we'll get right started. So the first thing today, we're talking about carpal tunnel syndrome, and this clearly is a picture of a wrist. And the purpose is, generally speaking, wrist pain. And when someone is having wrist pain, carpal tunnel syndrome is going to be on those list of things. It can present in many different ways. So wrist pain is, generally speaking, going to be the chief complaint or the primary reason that someone is coming to see me with carpal tunnel syndrome. So our objectives today, we want to understand the basic symptoms, so kind of the ins and outs and how to differentiate it from other problems that we may run into. We want to understand the basic anatomy and the cause of carpal tunnel syndrome. That's a very common thing that gets asked me by my patients in the office. I want to kind of explain the treatment options and when to see your doctor, and why one treatment option makes more sense or is more appropriate for you. Certainly these things are options, and they're not the only way we can take care of things, but there are some warning signs that we really need to pay attention to in order to have a good outcome. And we want to understand the recovery and the expectations of how this gets better, and what can I expect as far as chances that the carpal tunnel comes back, or when it may come to surgery. So our common symptoms, the big one, numbness, is the biggest one. Numbness, tingling, which is the doctors call paresthesias. That is that pins and needles kinds of feelings, and it can be any version of burning, cold, sensitivity to touching things. It has lots of varieties. Pain is usually the part that's going to keep us awake at nighttime or wake us up from a dead sleep with our hand painful, cold, and numb at the same time, which, unless you've experienced it, can be very difficult to understand, but very much can happen. Carpal tunnel syndrome typically is a combination of these three different basic symptoms. And it can be just one, it can be all three, any version. It just depends on how your nerve is responding. The general distribution of this pain, numbness, and tingling is going to be the thumb, index, middle finger, and usually the thumb side of the ring finger. Now, certainly we are not put together all the same. That's what makes my job much more fun. But picking out the individual pattern that you have as part of what the physician taking care of you is going to need to figure out. But generally speaking, and most commonly, it's going to be from the thumb to the ring finger, mostly on the thumb side of the ring finger. And the clicker's not working. So other symptoms, these are some of the things that we're particularly concerned about. Muscle atrophy is one of them. The arrow is pointing towards the base of the thumb on the palm side of the hand. And in this picture, we can see the fading away of the normal muscle. It almost looks like an elephant sat on it and then got back up and left a dent. This is a very extreme case of that. The hand that you see on the right side of the picture has less atrophy than the left side. And it is a very slow, gradual process that can occur anywhere between 10 years or sometimes in a period of a number of months in more severe cases. But in every case, atrophy is something that we want to be approaching our doctors about. Dropping items is one of those symptoms that is subtle, and the specific dropping item event occurs when you think you have the glass of water or the cup of coffee, mug of coffee in your hand, and all of a sudden you hear it hit the floor when you thought you had it in your hand. Dropping items is one of those concerning findings that we see. And if that occurs, it is absolutely worth checking in with your hand surgeon, with your primary care doctor, because that can be a sign of progressive carpal tunnel syndrome or other medical conditions that are worth treating. Difficulty with simple tasks. This is the picking a key out of a drawer, figuring out which button is which, getting something out of your pocket and deciding, what is actually in your hand, difficulty with small buttons, screws, tying a tie, these kinds of things. It's that I should be able to do this, but my hands aren't doing it right. And that is absolutely one of the signs of more concerning progressive conditions. Difficulty sleeping, this goes in with the numbness, tingling, the pain, the waking up at nighttime, feeling the need to shake your hand off at the side of the bed or hang it off for minutes. Sometimes in more severe cases, people are walking back and forth across the house or living room because they can't get back to sleep. All of these things are other things that a physician should be taking care of. And the button again. I don't know if the thing is done. So those are the basic symptoms, and now we're going to start understanding the basic anatomy. So this is kind of a transparent cutout of the palm of the hand. And we'll see, if you look on the right side, we'll see the median nerve. That is the very large nerve trunk, which is going into the carpal tunnel syndrome under the ligament, which is running crossways across it. And you'll see as the nerve branches break out that it's going to the thumb, the index, the middle finger, and the thumb side of the ring finger. You'll also see another gray nerve trunk on the left side of the wrist, and that is going to be the ulnar nerve, which we can go into more detail in questions, and can sometimes be confused as carpal tunnel syndrome, but is very distinct from it for lots of reasons. But we can go into that more detail if people wish. Here's another picture of the anatomy, and this one we're including a color-coded one. And so the median nerve in this picture on the left is the yellow nerve fibers. And so you see the large trunk going underneath the transverse carpal ligament, spreading out to the different nerve branches, including a very small branch going to the muscle at the base of the thumb. When that nerve is no longer functioning well, that's why we get the atrophy in that spot at the base of the thumb, because the median nerve, or the carpal tunnel nerve, feeds that muscle and keeps it alive and functioning. On the right side, we see a cross section, much like we would slice through a loaf of bread. And you can see the space with the median nerve as being that yellow structure right in the middle. The light blue are the tendons that also occupy the space in the carpal tunnel. You'll notice that the carpal tunnel is oblong. It's shaped like an oval. And the bluish transverse carpal ligament running on top is the roof of the carpal tunnel. As that transverse carpal tunnel ligament gets thicker, it will push down on that yellow median nerve and squash it into the bones, which make the floor of the carpal tunnel. It is an unforgiving space, and once this transverse carpal ligament gets thicker, the nerve getting squashed is the natural consequence of it. We'll discuss some of the treatment options and why we approach it the way we do, but understanding that it is a confined space with tendons and a nerve that has nowhere to escape to will help understand why this happens. Here's another picture again. We're seeing the transverse carpal ligament. We're seeing the nerve fibers, the thenar muscles, which are the muscles at the base of the thumb. And in this particular case, the flexor tendons are highlighted. Those flexor tendons are also occupying the space of the transverse carpal tunnel, or the carpal tunnel space. And they are much more rigid. And if an object or a structure is going to get squashed in the carpal tunnel, it will be the carpal tunnel nerve, the median nerve, because it is not as resilient as the tendons are. When we're testing for carpal tunnel syndrome, very often we'll get x-rays. The primary reason for getting x-rays before an evaluation is we're looking for arthritis type reasons, which may be aggravating the carpal tunnel, and also arthritis or fractures in the case of an injury, which may be pretending to be carpal tunnel syndrome. It helps in the diagnosis of picking out the nerve-related condition versus the structural related condition, which would involve the bones or the joints. When we're performing a physical exam for carpal tunnel syndrome, the Durkin's test is one of the more common tests that we use in the office. And if one of my patients with potentially carpal tunnel syndrome sees me, this will be one of the early things that I do to look for carpal tunnel syndrome. And what we're doing in this picture is we are putting direct pressure over the median nerve in the carpal tunnel space, just a little bit closer to the elbow from the wrist, where the nerve is the most sensitive. What we're trying to elicit or initiate is increased numbness, increased pain, and increased tingling in the fingers where the median nerve goes, namely the thumb, index, middle, and part of the ring finger. Generally, we hold this until there are symptoms, or approximately 1 minute. If it does not create any symptoms within 20 to 30 seconds, generally speaking, it would be a negative test, meaning not indicative of carpal tunnel syndrome. The next test that's commonly used is called the Phelan's test. And in this test, we are flexing the wrist together and testing both at the same time. This is simulating what happens to us at nighttime while we're sleeping, in which case we curl into this seemingly fetal type position where we curl our wrist and curl our fingers while we're in our deep sleep. In this position, it is compressing the median nerve even more. You can see by the indicated arrows on the left side. In this position, there's even less room for that median nerve, and it creates symptoms much like pushing directly on it, as the Durkin's test. A Tunnell sign in this picture, what we're seeing is we are seeing literal thumping of the wrist over that median nerve. We are trying to elicit sensitivity, specifically a shocking sensation that goes down to the tip of the fingers. Most frequently, this is going towards the fingertips themselves. On occasion, it will go actually towards the elbow instead, approximately 1 out of 10 times. If there's no sensitivity of the nerve there, it feels like a simple reflex when the doctor is hitting the front of our knee, that we'll get a slight jump, but no shock, no tingle, no discomfort from it. So if we have positive tests, and we have positive tests on physical exam, we have the signs and symptoms of carpal tunnel syndrome, very often your physician will discuss a nerve conduction test. Nerve conduction tests are very frequently ordered by the primary care physicians as an appropriate diagnostic tool for identifying carpal tunnel syndrome. The basic idea is we are trying to basically check the speed of a signal or an impulse across the space of the carpal tunnel. In this picture, you can see one of the electrodes, and it is quite literally a zapper. One of the electrodes over the wrist, we're trying to see how fast that signal gets to the thumb or to the index finger or to the muscles in this part of the thumb that nerve goes to. And we're checking the speed against against constant normals, although all of us are a little bit different than one another. We are also going to compare one side, let's say the left side, from the right side. So even if you only have symptoms on one side, they will check both, and using the normal side as a comparison to the other side. And we're looking for a difference in the speed in which that signal goes from one spot to another spot. Also in the nerve conduction test, we are looking for other nerve roots and nerves that may be compressed, such as nerve roots in the cervical spine, which may be getting compressed in between the vertebrae or the bones in your neck. If you have compression there, the symptoms may actually be in your hand. It is the same fibers that run all the way down to the fingertips and to the thumb, and it becomes very difficult for our body to be able to tell where that nerve is compressed. The analogy I often give people is a garden hose in your backyard. A garden hose in your backyard, if the water is no longer running, you turn around and look to see where the kink is. The kink can be right by the spigot. The kink can be right underneath your foot. We can have 2 kinks in the garden hose. The nerve test helps pick out where those kinks are, and in coordination with the physical exam findings can be very helpful. It also can come back being completely normal. Again, our wiring can be a little bit different one person to another person, and some of us, just as far as our nervous system goes, don't fit into normal. I'm supposed to normally have hair, but I don't. So that is just one of those variations that we can expect. So a normal test does not mean you don't have a problem. A normal test means that we need to be a little bit more creative and do a little bit more work to figure out what the problem is. Treatment options. There are many different treatment options for carpal tunnel syndrome, and we'll go through those briefly. As a physician, I'm very conservative. Not everybody needs surgery, especially right away. Very frequently, people with diagnosed carpal tunnel syndrome eventually need surgery to correct that problem, and I'll explain why shortly. But that is certainly not the starting point. My primary goal, not only for taking care of carpal tunnel syndrome, but taking care of all of the musculoskeletal conditions I take care of, My primary goal is to make sure that you're able to do the functional things you need to do, either for work or for fun, without difficulty. If there is a problem that is interfering with those activities, say dropping a coffee cup in the morning, which in my opinion is inappropriate, then we need to solve the problem or go to whatever next step there is to be able to get you better. But surgery is not always the first step. In fact, most often for carpal tunnel syndrome, it is not. But it is certainly an option that we'll discuss. Bracing, the primary role for bracing is at nighttime while we're sleeping. The primary reason being at nighttime, we put more pressure on our median nerve as we sleep, and then wake up and have symptoms, the numbness, the tingling, the pacing, the discomfort. Wearing a brace at nighttime while we're sleeping helps prevent the positioning of the wrist, helps rest the wrist so that you get a good night's sleep while your nerve gets a good night's sleep. And in the morning, your nerve will be more resilient, more awake, and happier, and less likely to cause symptoms during activities during the day. It is a very good non-operative treatment for carpal tunnel syndrome before we start having atrophy and before we start finding permanent signs of nerve dysfunction or nerve problems. Very often, if this is one of those devices that people come into the office to see me and they've already tried it, in which case we very often go to the next step. The next step would be a cortisone injection. The cortisone injection for carpal tunnel syndrome has multiple purposes, but the first and foremost one is to help relax, calm down, remove or resolve the symptoms of the carpal tunnel syndrome that you have. And that is numbness, tingling, and pain. Very often the carpal tunnel injection with a cortisone very frequently works better for the tingling and the pain. The numbness, if it's full-time numbness, the cortisone injection can sometimes not relieve that, but can definitely make sleeping easier, can make the overall symptoms better. If there are leftover symptoms, very frequently, we would like to follow up with a patient after a carpal tunnel injection to check to see what is better and what is not better. The reason for that is the second reason for an injection is for a diagnostic injection. In other words, when we're doing a carpal tunnel injection with cortisone, we are only treating the carpal tunnel syndrome. So whatever gets better is the carpal tunnel syndrome. If symptoms are left over, it's a different problem, i.e. a nerve root compression in the neck, arthritis, a different nerve that's being compressed. So by doing the carpal tunnel injection as a reasonable next step, we are staying relatively conservative, slightly more invasive, but we're doing a diagnostic and therapeutic test, which generally speaking can last for several months in many people, on occasion even several years, if the carpal tunnel syndrome is relatively more mild. We do this generally speaking when the bracing is no longer being effective or when the symptoms are severe enough that for patient relief, it's a reasonable next step. The carpal tunnel injection is always voluntary, and it's something that we would discuss during our visit. Cortisone with ultrasound is another method. It's a slightly more modern method for doing a cortisone injection, in which case an ultrasound device is used to identify through ultrasound the anatomic space or the space in the carpal tunnel where we would like to put the injection. This allows us to more specifically isolate the place within the carpal tunnel close to the median nerve, but without the risk of injury to the median nerve. In this picture, you can see the big M is the median nerve, the T's are the tendons, the B's are the bones, the RA is the radial artery, which we certainly do not want to hit with a needle. And in this picture, the bright white line with the arrows pointing at it, that is the actual needle that we're doing the injection with. The effect of doing a carpal tunnel injection with ultrasound is ideally the same as doing the carpal tunnel injection anyway. It is mostly a difference in technique. Your physician may or may not choose it, but generally speaking, we want to stick with what the physician does most frequently because that will be what they're going to have the best success rates with. This would ideally be done by someone that has been trained to do it, much like being trained to do a carpal tunnel injection. Surgical techniques. So the surgical techniques are reserved for more severe carpal tunnel syndrome as defined by the nerve conduction test, by failure of the other conservative treatments, meaning bracing and cortisone injection. And the surgical treatment for this comes down to multiple different techniques, which all have a similar purpose. And the similar purpose of these are primarily to relieve the pressure on the median nerve. The transverse carpal ligament is the offending structure. That is the ligament that, for reasons we cannot fully identify, is compressing the nerve beneath it. We cannot remove the bones. We certainly do not want to remove the tendons, but we can certainly make more room for the nerve to heal, to recover its blood flow. By doing this, we cut through the transverse carpal ligament to mechanically create space for the median nerve to relieve the syndrome, the carpal tunnel syndrome. The severity of the symptoms beforehand, the level of atrophy over the thumb, and the amount of numbness or tingling in the fingers will determine how fast that nerve can recover. More severe carpal tunnel syndrome may take many months to recover. Less severe carpal tunnel syndrome may recover regarding the nerve itself, may recover relatively quickly within a matter of days. Very often in slightly less severe cases, kind of middle to mild cases, that evening patients sleep better than they did before the surgery because the nerve-related pain is resolved immediately. The numbness in particular can take sometimes many months, but we monitor your progress in the office after the surgery to be sure that you are making the recovery we expect. This technique of releasing this transverse carpal ligament can be done multiple ways. The open technique is essentially the gold standard based on the training of the surgeon taking care of you. It has been done for roughly 45 years. In the beginning, we did very large incisions, which encompass the entire wrist and a majority of the palm. Now, most surgeons are trained in what we call a mini open technique, which is more appropriately diagrammed on the right. It is a roughly 1-inch incision in the palm directly over the transverse carpal ligament to maximize their ability to completely release the median nerve in this location. After the surgery, people would expect soreness, improvement in nerve symptoms, with some residual that would require more time to recover from, again, depending on the severity of the nerve. An endoscopic release was popular and still remains popular among certain surgeons. The endoscopic release is done through smaller incisions, on occasion one at the base of the wrist, which is just shy of the transverse carpal ligament, with the purpose of it being putting the device underneath from an elbow to fingertip direction, underneath the transverse carpal ligament and cutting through it from the underside. And in the two circular pictures on the bottom of the page, you can see that white band on the one on the left, the white band, that is the undersurface of the transverse carpal ligament with the blade angled and pointing up because we're cutting through the undersurface of it. And then the picture on the right, the circular picture on the right, is demonstrating the transverse carpal ligament released and slightly open. We'll discuss the benefits and risks of these two techniques. Recovery is similar, but we'll go into more detail. Aftercare of this requires basically tender loving care. We want to pad it, we want to protect the wrist and prevent outside bacteria from getting through our surgical incision. So keeping it clean and keeping it dry is the standard of care. Generally speaking, that period of time is approximately 10 days. Every surgeon will have their own way of doing it slightly, but generally speaking, it will be a week and a half. In my clinic and in my office, and post-surgical care is 10 days afterwards, where in that 10-day period of time, we want to keep it clean and dry. Functional use of the hand and the fingers is allowed, but trying to hold back from things that cause extra pain. So comparing the mini open technique versus the endoscopic technique, and orthopedic surgeons, hand surgeons, we discuss this, we joke with each other, we compare data, but the truth of the matter is both of them can be very effective. Generally speaking, as a patient, I would want my surgery done by whichever way the surgeon does it most frequently. The excellent results will come from lots of practice. The more surgical releases a surgeon does, the better they're going to be at it, no matter which technique they have adopted. A mini open technique generally has a faster surgical time, roughly around 8 minutes or so. If I joke with patients often, if I'm having a good day, it'll be about 6 or 7 minutes. If I'm having a bad day, it'll be about 9 minutes. But either way, it will be within that 8-minute range. This is usually done with sedation or sometimes under just general or just local anesthesia if there are concerns about certain airway problems based on the anesthesiologist. On occasion, they are done under general anesthesia, but usually done under some sort of local anesthesia, plus or minus some sedation. The mini open technique has the lowest cost. There's no extra equipment that's necessary other than a fresh scalpel blade and the stitches that we use to sew the skin with. And because of that, because there's no extra device, it is the cheapest way to do it. Lower rate of nerve and tendon injury, and this has been proven in multiple studies. Again, there are certainly studies that show endoscopic techniques are safe and effective, and some large studies that show an incredibly low incidence of nerve or tendon injury. But again, this comes down to the experience with the surgeon. The more experienced they are with their technique, the lowest the chance of injury will be. Mini open techniques, because we are looking directly at the nerve from the outside, they have the lowest recurrence rate. In other words, from the beginning of the carpal tunnel to, in other words, the fingertip side, to the elbow side of the transverse carpal ligament and carpal tunnel space, I am visually seeing it with my eyes that the nerve has been released and it is decompressed. I can look my patients in the eyes afterwards and say, yes, sir, yes, ma'am, that nerve is released. I saw it myself. And so because of that, it has the lowest recurrence rate, the lowest chance of missing a portion of that ligament or a portion of the muscle, which is continuing to press on the nerve and did not get decompressed during the surgery. The disadvantage of the mini open technique is the sensitivity where that incision is does remain sore for a longer period of time. In the studies, they compare approximately 4 weeks of soreness in the endoscopic technique versus 6 weeks of soreness in the mini open technique. Again, every patient has their own way of recovering, and some people are certainly quicker than others, and these are based on averages. But the increased scar sensitivity for a roughly on average 2-week period of time is the one disadvantage to the mini open technique. As far as being able to use the hand afterwards, they are roughly the same for the first 4 weeks, 4-week period of time. And the result at 3 months after the surgery, they have equivalent results with equivalent activity tolerances. In other words, people are doing just as well at 3 months. It really is in the shorter term what the experience of recovering will be like. The endoscopic technique, one of the big advantages, less scar sensitivity, and that is what the technique was designed for, is to not make an incision in the slightly more sensitive palm skin at the base of the thumb. The scars are generally smaller, although with the mini open technique and experience of doing it over thousands of times, that difference can be on the matter of 1/4 of an inch or 1/2 an inch in size difference, barely enough to put an extra stitch in. But generally speaking, they are a smaller scar. The surgical time is longer, which generally means more anesthesia if anesthesia is being used, more cost because being in the operating room does cost extra money, and the longer you're there, the more the surgical cost is. And generally speaking, again, depending on the skill of the surgeon and their experience, it will affect this general surgical time. There is a higher cost. The actual endoscopic devices, there is money associated with that. And so that is an extra device that ends up on the charge. There is a higher rate of nerve and tendon injury. Again, with the experience, that is absolutely decreased. But there, in the comparison of the two techniques, there is a higher technique. An injury to the nerve or tendon could be significant, generally repairable, but always unpleasant and always creates a longer recovery time. So one of the questions that I'm sure I'll be asked before I approach the when is it time is, are there other techniques or other things that we can do to either delay or treat carpal tunnel in a less aggressive or less invasive manner? And the caveat I would say to those other techniques and those other questions is remembering that the problem itself is generally a mechanical problem. That transverse carpal ligament that gets thicker over time, the exact cause of which we're not sure of, it does not get unthick. It does not get softer again. It does not get more flexible. And although we can make the nerve healthier and we can help the symptoms, we are not going to correct the mechanical problem of the carpal tunnel syndrome. And whether it's by braces or by cortisone injections or therapy or nerve gliding techniques, ultimately the end result of carpal tunnel syndrome is carpal tunnel surgery to take the direct pressure, the mechanical pressure off of that nerve. When I'm caring for patients that would like to approach these these slightly more complicated and more technical non-operative techniques like nerve gliding exercises with physical therapy, they can be effective, and certainly they can be part of the treatment plan, with the understanding that we don't want to delay surgery past the point where we can have a meaningful recovery. But absolutely, those things can be discussed more on an individual basis and on a one-on-one basis. So when is it time to actually see the doctor? When is it time to get a consultation with a hand surgeon? And when is it time to be a little bit more worried about the numbness and tingling that I'm experiencing? Well, certainly when the problem is interfering with work or fun. We're not supposed to just be working all the time. We're certainly supposed to be allowed to have fun. It's certainly been challenging over the last several months due to the lockdowns and coronavirus and being careful and smart and safe for our friends and family. But when carpal tunnel syndrome is interfering with the things that you would need to do or would like to do, that is certainly the time to check things out and get seen. Because again, very often the carpal tunnel syndrome is not at a point where we need to jump into aggressive treatment. Very often we have non-aggressive treatment plans available for you when they're appropriate. When atrophy is present at the base of the thumb, we are entering that permanent change level of carpal tunnel syndrome. When that is starting to happen, we're starting to end up with a compromised recovery. Carpal tunnel syndrome, when caught in its milder form and there's no atrophy, the symptoms are in and out. Carpal tunnel releases have essentially a 100% recovery when it's carpal tunnel syndrome, certainly. But in cases where it's more advanced, where the numbness is more severe, where there's physical atrophy present, we have the chance of a compromised result. So certainly when you start seeing atrophy at the base of the thumb, it is certainly time to seek evaluation. When the numbness in the fingers is constant, in other words, at nighttime, if it wakes us up and we shake our fingers out and we get back to sleep, the nerve is still healthy as long as during the day things are good, not having trouble fastening buttons, not having trouble picking things up, not having numbness that's present all the time. When that numbness starts being present all the time and there is no normal anymore, that is certainly one of those warning signs that carpal tunnel syndrome is becoming permanent with permanent damage. Earlier is better. When it's off and on, we're still safe. When there's no atrophy, we're still safe as long as you're still able to do what you need to do. The other time to do it, and on occasion, the carpal tunnel symptoms are more pain than numbness or tingling, and you can't stand it anymore. And I absolutely see patients that are dealing with the shaking the hands out. They've tried the braces. They've done well for sometimes, in some cases, even 15 years, as someone I saw earlier today, but they're doing okay. And then they reach the point where the symptoms get worse, the pain gets worse, and they can't stand it anymore. What we try to avoid in the treatment of carpal tunnel syndrome is ever hitting that point where the pain is starting to affect your ability to function, ability to sleep at all, or just, this excruciating, because carpal tunnel certainly can be. It is not the normal for it, but it certainly can be. And so if you can't stand it anymore, it's time to seek a consultation and seek evaluation and treatment. So common concerns, will my carpal tunnel syndrome come back? That is a very common one I get, and we often have a belief in the community and among other people and even among my family that I don't want to get my carpal tunnel treated because it's just going to come back. So why would I have surgery to have something that's going to come back? And the answer is when carpal tunnel syndrome is appropriately diagnosed carefully and thoughtfully, and the carpal tunnel surgery to correct it, if that is what is done correctly, Carpal tunnel syndrome only comes back 4% of the time, which means 96% of the time, the carpal tunnel is fixed for life. Certainly, the younger you are when you have your carpal tunnel syndrome and have it corrected, the longer there is for it to happen. But statistically speaking, it usually comes back at approximately 15 years after the surgery is done. The patients that get beyond that, if there is numbness and tingling, it is usually not the carpal tunnel syndrome. It's usually a different nerve-related problem, and certainly is worth evaluation. But generally speaking, 96% of the time, it does not come back and is worth treating. Is my nerve permanently damaged is a common one I get. And very often I get it from people that just have the concerns and the reputation of carpal tunnel syndrome and not exhibiting the atrophy or the loss of muscle in the thumb. They have symptoms that come and go, and their nerve is actually quite healthy. It's just getting worse. In those circumstances, the nerve is not permanently damaged and has a miraculous ability to recover from chronic nerve compression. The key is, in the more severe cases, to get to those earlier rather than later. The sooner that we treat it, the better the outcome will be, almost always. Did my job cause carpal tunnel syndrome? And this is one, there have been many surgeries, or there have been many studies with the concern that using a keyboard, using hydraulic tools, being in a certain position or being a hairdresser, a lot of these things that we do with our hands, is that causing my carpal tunnel syndrome? The direct answer to the question is we don't have proof of it, and we're entirely not sure. Certainly certain conditions and certain work positions and certain work types can aggravate carpal tunnel syndrome, can magnify symptoms of carpal tunnel syndrome, but the original cause and the original thickening of the transverse carpal ligament, we have no great explanation for, either genetically or from heredity in our parents and grandparents, or from our activities. We're not entirely sure what makes it happen. Although certain activities can aggravate it. If it is happening, if the symptoms are more commonly occurring at work, again, worth an evaluation, because other conditions and other syndromes and things like tendinitis and arthritis can be aggravated as well. Certainly worth the evaluation. But proving the cause of carpal tunnel syndrome and a work-related condition can be very difficult for the physician and for the patient. I've heard carpal tunnel syndrome or carpal tunnel surgery doesn't work. So I taught orthopedic residents for many years, approximately 9 at the University of Florida, 9 years. And this was a very commonly occurring question in the community, and not only in the medical community, but the actual community of friends and family and people that we work with and people we know. Carpal tunnel surgery does work actually quite well. Again, it's a mechanical problem, and when the mechanical problem is solved by creating more room for the nerve, it works. The times when it does not work are 2 main times. One time is when the carpal tunnel syndrome is so severe, the damage is permanent. There's atrophy, there's numbness all the time, in which case it might not work completely, but it almost always will improve the symptoms that you have, and is still worth pursuing, almost always. Very rarely do I recommend leaving a carpal tunnel as it is, even when the symptoms are quite severe, because recovery, even a partial recovery, can make a very meaningful difference in function. The other reason for carpal tunnel surgery not working is because the problem was not carpal tunnel syndrome, which is one of the reasons why a thorough evaluation is very important in being sure that we go through the treatment steps, we go through the bracing, the injection, occasionally a nerve conduction test if warranted or if the picture is unclear, and we go through the steps to getting you better, and to be sure that your surgery is done by someone that is experienced doing it. In the hands of a surgeon that is experienced with it, in a patient with carpal tunnel syndrome, the surgery is a remarkable success and should be pursued when all other treatment plan options have failed, or when there's more concerning carpal tunnel syndrome. So other related conditions which can occasionally be concerning or overlap with carpal tunnel syndrome, again, remembering that we can have more than one problem at the same time. I can have back pain and I can have ankle pain at the same time, and it can be sometimes difficult to pick one from the other without the context of a new injury. Injuries have a tendency to be slightly more obvious. One of those conditions in carpal tunnel syndrome can be a herniated disc in the neck. Again, going back to the analogy of a garden hose in your backyard, you can have more than one kink than the other. We can have a herniated disc in our neck and carpal tunnel syndrome in our wrist, and both of those together create a condition we call a double crush phenomenon, or a double crush syndrome. That nerve is more susceptible to another compression when it's already getting compressed in one spot to begin with. The trick is picking out which one is the bigger of the two injuries and discussing surgical risk of fixing those two injuries. Correcting a carpal tunnel syndrome is certainly less risky than surgery around a cervical nerve root in the neck or decompression of the cervical spine. Recovery also can vary in those different techniques depending on the condition, depending on the severity of the nerve root compression in the neck. Recovery from carpal tunnel syndrome is significantly more consistent. And in the case where I have two nerve compressions that I'm concerned about, and I've identified both of them, if carpal tunnel syndrome is part of that equation, I usually recommend correcting the carpal tunnel syndrome first because of the lower risk and the ease of recovery. Cubital tunnel syndrome. Cubital tunnel syndrome is a nerve compression syndrome in the arm where the funny bone nerve or the ulnar nerve is being compressed in the elbow. It is not quite as common as carpal tunnel syndrome, but remarkably common overall, and very commonly exists in conjunction or at the same time as carpal tunnel syndrome. It presents with slightly different symptoms, generally speaking, more pinky finger and ring finger symptoms, and atrophy in different locations, generally between the thumb and the index finger is where the atrophy generally presents, but a similar basic condition with a similarly relatively simple correction. Physical therapy is slightly less effective. Bracing is much less effective. Cortisone shots for cubital tunnel syndrome have a significantly different risk profile and are very often not pursued. But the surgical release of the cubital tunnel syndrome recovers even faster than the carpal tunnel syndrome does. And I often recommend, when presented with a patient who has carpal tunnel syndrome and cubital tunnel syndrome both in existence at the same time, I recommend a surgical release of both at the same time. The addition of releasing a cubital tunnel syndrome rarely prolongs the recovery of the arm and the hand and the wrist overall. It is very often recovers faster than the carpal tunnel surgery itself, and it increases our chances that we wake up fixed, happy, numbness and tingling resolving, strength and function improving. Radial tunnel syndrome is a very challenging problem to identify, and much more identified in the hands of somebody with experience treating radial tunnel syndrome. It is a nerve compression in the forearm, closer to the outer side of the elbow, very commonly close to where we would consider someone having tennis elbow. It creates symptoms across the back of the hand, generally burning, tingling, sometimes numbness. The pain can actually be quite significant. Radial tunnel syndrome often gets people uncomfortable before they fall asleep. If someone is having difficulty falling asleep in the first place, it's very frequently radial tunnel syndrome. If they wake up from a deep, comfortable sleep with numbness and tingling and pain in their hand, it's usually carpal tunnel syndrome. But in the hands of an experienced hand surgeon, we'll be able to pick out these differences in the office and explain what part of the symptoms are what, and help you understand what these mean and how we take care of them. Peripheral neuropathy, the most common cause of peripheral neuropathy would be diabetes. Over time, diabetes can have effect on the peripheral nervous system, peripheral meaning more fingertips, toes, foot, ankle. Peripheral neuropathy in the hands is much more uncommon than in the feet, but all come into play when trying to diagnose carpal tunnel syndrome and in the discussion of what are my expectations for the recovery of surgery, of an injection, of bracing. Peripheral neuropathy is much more challenging to improve, and very often physicians don't have great solutions for it. If someone has numbness or tingling in the hand, they frequently come to me thinking that it is their diabetes that's causing the problem, And although that can be part of the issue, very often carpal tunnel syndrome is the culprit because, again, numbness and tingling in the hand can be caused by multiple things at the same time. And when they occur and when they interfere with work and function, evaluation by someone with experience is most appropriate. So picking a doctor, obviously, I would say pick me because I'm fantastic. But I would love to say also that I have a monopoly on getting people better with carpal tunnel syndrome and with other upper extremity problems. But there are many well-trained, well-experienced orthopedic hand surgeons in the community. I am but one. But picking one in Southeast Orthopedic Specialists, we certainly have two excellent hand surgeons, one being myself and the other being Dr. Christopher Gall. Either one of us would be more than happy to take care of you. But if you are not being seen by one of us, be sure that the physician taking care of you has experience with carpal tunnel syndrome, has experience with nerve compression syndromes, and is appropriately trained, preferably with a fellowship training, in those conditions to be sure that when you get taken care of, you're being taken care of by the best. So when you see your physician, whether it's myself, and I would certainly hold me to the standard that I preach, or you're seeing another physician, make sure that they're doing a thorough examination. If all they are looking for is carpal tunnel syndrome, all they will find is carpal tunnel syndrome. These other conditions that occur at the same time and can overlap with carpal tunnel syndrome are only going to be found when you're looking for those things. They very frequently do not show up on a nerve conduction test, and they very frequently are identified by a very thorough and careful physical examination. So when you see your surgeon, make sure that they've appropriately diagnosed you with carpal tunnel syndrome and they're performing the thorough examination to rule out the other problems that may lead you to think that carpal tunnel surgery doesn't work because they never identified the other problems. And I'm a big fan of asking questions, which is going to be the next phase of this seminar tonight. In the office, when you're seeing your surgeon, one of those telltale signs of what kind of doctor is taking care of you is when you ask questions. When they answer those questions, when they give those questions thought, and when they explain them in a way that you can understand, that's going to be a doctor that is going to take good care of you. Doctors can't understand what the problems are unless they understand what you're feeling, and they can't understand what they're feeling unless you can express what you're experiencing and then be able to hear what you're experiencing. So if you're leaving the office visit and the consultation with questions that really haven't been answered, then it's appropriate to get another opinion. Because generally speaking, if they're not answering your questions, it's because they don't care about the other things going on, or they're too busy to identify the other problems going on. So be sure if you have questions, ask the questions because those are important. So at this point, and I'm sure there are lots of things that I've missed, it's a topic that starts from very small to can last hours. And certainly in the world of orthopedic hand surgery, it can be discussed in detail for hours. But if there are questions that you have, and I know we had some that were written and sent to us before the seminar began, and I hope there would be a couple from the seminar itself, we'll go through those questions now. Now, if there are specific questions for me and my team with Southeast Orthopedic Specialists, the phone number is listed. That phone number goes specifically to the team of people working with me. You may leave a voice message and we'll get back to you either to schedule a visit, schedule a consultation, or be able to help you in your care. An email can also be sent to puckettteam@seortho.com with a similar result. We read those emails daily and we'll get back to you to coordinate either a visit or to help in your care any way that we can. So absolutely it can. And it becomes a little bit of a tricky thing because many things cause swelling. On occasion, swelling can be caused by tendinitis, and we can have tendinitis in our wrists. The tendons that move our fingers and bend our wrist down are susceptible to tendinitis as well, and the nerve occupies the same space with those tendons. Therefore, if the tendons are swollen and taking up more space, the nerve is getting compressed also by the tendons and the transverse carpal ligament, which is particularly unfair. In those circumstances at nighttime, when we bend our wrist down and we kind of snuggle into sleep, we are compressing that tunnel space. We are narrowing that channel that we have for the nerve and the tendons, and we are increasing the swelling that we have. It's much like if I push on some of the veins on the back of my hand, those veins will get more blood in them as they congest. And that happens with the tendons and the nerve as well at nighttime. So to wake up in the morning and have swelling in both of your hands from being in this position overnight absolutely can not only be a sign of carpal tunnel syndrome, but it can be aggravating carpal tunnel syndrome. One of the reasons why starting with a brace is a very good conservative measure. A cortisone injection can also help calm the tendinitis and the carpal tunnel syndrome at the same time. Now, there are certainly overlap conditions that can interfere and cause other tendinitis other places in the hand. The beauty of being a hand surgeon is we never run out of tendons to have tendinitis in, which keeps us very busy. And certainly the tendons down in through here and the tendons in the fingers can get tendinitis in them. And that can also aggravate swelling in the hands, particularly in the morning. So this is a fantastic one, and it will honestly vary between surgeon to surgeon, doctor to doctor. It really, for first and foremost, it depends on the effectiveness of the first injection. And so for me in my practice, if I do a cortisone injection as part of the treatment plan, and we just knock it out of the park, carpal tunnel syndrome gone, everybody's happy, I'm happy, my patient's happy. They're sleeping better, they're doing things during the day and not aggravating their carpal tunnel syndrome and not feeling any symptoms. And then a year later it comes back, I would be hard pressed myself to do surgery on myself instead of having another carpal tunnel injection. And so the short answer is, if it is effective, it's a reasonable treatment plan, at least in my practice. There is always risk with doing injections, but the risk by a well-done carpal tunnel injection in the hands of somebody experienced, that risk is very small. If that carpal tunnel injection is either not completely effective or lasts for a very short period of time, and in my hands, it's generally, if it's lasting less than 3 months, it's not an effective treatment plan, and we probably need to start discussing what the surgical options are and why that would make more sense. On occasion, it comes down to timing. For example, right before a very busy portion of the year as far as work activity, well, that may be a terrible time to recover from a carpal tunnel surgery. And so a carpal tunnel injection, even though it's not a permanent solution to the problem, may get us through that very busy period of time, whereby we plan on correcting the carpal tunnel syndrome with surgery after that period of time ends. So as a stopgap, it can also be very effective. The answer is yes. The studies on diabetes and carpal tunnel syndrome are conclusive. Now, that does not necessarily interfere with the recovery of treatment of carpal tunnel syndrome. And it does not mean that we should not address the carpal tunnel syndrome because it can't possibly improve our symptoms. But certainly it does increase our risk and our chance of having carpal tunnel syndrome. But diabetes also increases our chance of having tendinitises in the hand and the wrist. And so, although we may be having carpal tunnel syndrome or symptoms, it may not mean that treating the carpal tunnel syndrome itself aggressively is going to be the right answer first time around. Because people with diabetes and struggle with diabetes certainly have a higher chance of other musculoskeletal tendinitises, particularly in the wrist and in the hand. And very often an evaluation is the best first place to start. That is a fantastic question. And in my career, I've been doing this independently for about 17 years. And I can honestly say that I've had about 4 people kind of convince me to get it done. Generally speaking, before the end of the year when deductibles are about to get reset and we have a little financial pressure to just get it done, sometimes because work, we just have to get back to it and we can't afford to step away from our business, or we can't afford to leave our team at work to be doing everything for us, and we just feel guilty and need to get back to it. Generally speaking, it's frowned upon to do both at the same time. And the reason for that is carpal tunnel recovery can sometimes be very straightforward, and within 2 weeks, people are back doing sometimes remarkable things in the gym, pushing weights, working hard, doing push-ups and doing great. And on occasion, we end up with one that is more sore, more swollen, more sensitivity, more angry at me for having done surgery on it. And we can't predict those well. Even one carpal tunnel release on the right hand, and then 6 months later, I do the left hand. One of them, it's a walk in the park. The second one takes 3 months before it finally calms down and gives it up. And it's the same surgery, the same procedure. There's no great indicator of one versus the other. And so if we do both at the same time, we run the risk of having both of them be bad, having both of them have a lingering recovery and not a good hand to get things done while they're recovering. And so, although I will very happily do them in a staggered measure, and very often I will take stitches out of one carpal tunnel while we're doing the release on the other side, because we did them about 2 weeks apart. And things like that are completely fine. It is more predictable. It gives us more kind of leeway in making sure that you have a good outcome. Now, I will do it if absolutely required, but people have to understand that the recovery can be more challenging. That's an awesome question. And a lot of times it really comes down to convenience on my patient's part. I would love to do every injection that on the patients I take care of. And I generally prefer to do the first injection myself. And there are two reasons for that. The main one is because it's the most convenient. If the injection has been authorized as part of the treatment plan by your primary care provider, or if you don't need authorization, and that's what we decide together is your appropriate treatment plan, we do the injection that day. And that injection is done by myself. In subsequent visits, we follow up. Generally speaking, the easiest way to follow up is with my PA. Right now I have one, her name is Jacqueline Tayo, and she's fantastic, has lots of experience and has been personally trained by myself, but not only in injections, but also in care. She's been working with me for about 2 years. And she is fantastic at doing the injections as well. She personally uses the technique with ultrasound. She does not have the same experience injecting these as I do, and has not done the several 10, 15,000 that I've done. And so for her, it's kind of a helpful kind of guarantee that we're getting it done in the right place, and makes it just a little bit more reliable for her currently. But if you would like to wait for me to do it, more than happy to do it the second time or the third time. If it's more convenient, Jacqueline is absolutely trained and well experienced doing it. Wonderful. That's a great question. So as we talked about the anatomy and we talked about why carpal tunnel syndrome happens, it can happen because of mechanical problems. There's not enough space. We are all made differently. We're made differently on the outside, we're made differently on the inside, and our carpal tunnels are made differently as well. And because of that, some people are just designed, they're just made with less accommodation for that nerve and don't tolerate extra aggravation to it, either because of swelling and injury or just bad luck. Some of us even have an extra artery that runs right on top of the median nerve in the carpal tunnel space. It is supposed to go away before we're born. It's supposed to go away. It is called a persistent median artery. And some of us have it still. It is absolutely associated with an increased risk of carpal tunnel syndrome. And about 5 times a year, I'll do a carpal tunnel release, and there's the artery. It has actually been on people that I've worked with and known as physicians, and we open up the space and we see the artery. That is an absolute setup for carpal tunnel syndrome, and those people that have been designed or anatomically have less space in their transverse carpal space, they are going to start having symptoms when they're young, sometimes even 20, 30. I have even seen teenagers with carpal tunnel syndrome. Generally speaking, our risk of having carpal tunnel syndrome goes up over time. It is not specifically related to age as a number. I don't believe in age as a number. I believe in age more as an attitude. But our risk does go up over time. And it's more just we've accumulated more wear and tear. We've accumulated more opportunities to have tendonitis. We've included more opportunities to have irritation to our transverse carpal ligament, and our risk goes up. But I take care of carpal tunnel syndrome from teenagers, although uncommon, all the way up to a 92-year-old that I saw earlier today. In all of those circumstances, carpal tunnel syndrome is safe and effective to treat. It is not something that I like people living with. Living with things is something we say to other people. It's not something we want to say to our loved ones or to ourselves. It really depends on the tendonitis. In the or in the world of hand and wrist surgery, cortisone injections are really a mainstay of treatment. But different types of tendonitis in the wrist and the hand can be treated completely differently depending on those specific types. Some of them respond very well and in fact can be cured completely with a single injection with cortisone. And a great example of that is a trigger thumb or a trigger finger, where the finger locks down in a flexed position. We pop it out, usually first thing in the morning. That responds very well and very frequently does not need surgery at all, with a single, sometimes two cortisone injections. Can happen in the thumb as well. And other conditions, one called mommy thumb, which is a tendonitis on this part of the wrist by the thumb and through here, very commonly seen in new mothers and new fathers. That can very often be cured and treated with a cortisone injection. So as a hand surgeon, cortisone is a fantastic treatment ally, and in some cases can be curative. In other words, it's not just a Band-Aid, it can actually fix it. And in other cases, it can be a Band-Aid temporarily, which is much more like carpal tunnel behaves. But if you're having pain, if you're having tendonitis and swelling, it's worth getting evaluated.